Welcome, Jalesh. This is your fourth lecture on the webinar. The first two were on bladder, which gave us a good insight into the anatomy, physiology, and some of the common disorders. The next was on synucleopathies and bladder disorders. And now we welcome you to give us a lecture on pelvic neurology, presenting with unexplained urogenital complaints. Well, Jalesh has already been introduced. Is there, and it's great to have two taking me time as we are already late. Jalesh, please start your presentation. The screen is all yours.
Okay, well, thank you. Good evening, everyone. At the outset, I'd like to once again thank Dr. Gajre, Dr. Kothari, Fine, for providing this opportunity to share principles of uro-neurology. And this is something that's closely related to pelvic neurology. And essentially, it's the approach to the patient who presents with unexplained urogenital complaints. This type of a case will commute as a referral to a neurology clinic. So it might be a referral from urology, from gynecology, from the gastroenterologist, or from the general physician. And essentially the patient would have some sort of lower urinary tract symptoms or sexual complaints, bowel complaints, or different sensory symptoms in the perineum, such as numbness, paresthesias, or pain. And the referring specialist has already investigated, has not been able to find a cause. And the question that's being asked to the neurologist is there a neurological cause for these unexplained urogenital complaints? So essentially all these urological causes would have been excluded by them. So as neurologists, we won't be investigating any of these, of course. The urologist or the gynecologist have already done those assessments. Now, the conundrum for the neurologist is that indeed, some neurological disorders can present with urogenital symptoms. Sometimes they can be the initial presentation, and sometimes they can be the predominant presentation of the neurological disease. And so we acknowledge that these conditions do exist. But once the urological cause has been excluded, how do we answer the question, could there be an underlying neurological disease responsible for these complaints? So there's some example of neurological disorders, lesions of the conus. I think in one of the earlier lectures I mentioned about MOG-positive transverse myelitis, which clearly is a neurological disorder that initially lands in a urology inpatient as a case of urinary retention. And during the course of a few days, the patient develops the other neurological complaints. But more commonly, we'll come across conditions such as tumors of the conus, or even other types of sort of focal demyelination, or even infarct of the conus. Lesions of the sacral roots, such as quite severe lumbar canal stenosis, inflammatory lesions in the setting of age. You have CMV, radiculitis. You have this entity of meningitis, urinary retention syndrome. Some cases of spina bifida, where it's predominantly sacral root involvement, so there might be very little lower limb signs. Sometimes you can have thoracic arteriovenous malformations that result in a sort of a steel phenomenon where there's a relative ischemia of the conus and the cauda. And so these patients can present with quite significant pelvic organ complaints, though the lesion is higher up. You heard about in earlier talks about neurodegenerative disorders such as multiple system atrophy. And also we need to think about sort of autonomic disorders such as your autoimmune ganglionopathies, for example. You need to think about pure autonomic failure. And you also think about sort of small fiber neuropathies where sometimes the patients can present with a predominant urogenital complaint. And the standard neurological examination may reveal little signs. So how do we approach? So this is something that's very much outside the comfort zone of most neurologists. And I think if you go back to the etymology of the word pudendal, it actually is derived from a word that means the shameful parts. And that sort of says it all, why neurologists are generally reluctant to really delve into this area much. It's quite an intimate history. So it's something that can't be done in a 10-minute outpatient clinic. it takes several minutes to even gain the patient's confidence to then engage them in a conversation about intimate matters such as sexual functions or bladder and bowel. And also the examination is also quite resource intense because invariably you need a chaperone when you examine the patient to look at the sacral neurology. And also it is quite time intense. I think most importantly, however, is that conventionally the pelvic neurological assessment is not really included within the realm of the standard neurological examination during training, nor during our practice. So it's something that's sort of very much out on a limb. But essentially what we need to think about is we have a patient with suspected problems. You need to think about the dichotomy that in the pelvic area you have the splanchnic innervation that innervates the lower urinary tract, the bowel, and the genitalia, and your somatic innervation that supplies the pelvic floor, the dermatomes in the pelvic region, and the muscles of the pelvic floor. And as a neurologist, we need to think about symptoms and signs that are related to both sets of innervation, which is rather complex because as a neurologist, we're more comfortable with an assessment of the somatic innervation. And here we need to think about the splanchnic as well. So your standard uroneurology history taking includes your symptoms that any neurologist would ask about neurological symptoms, but also we need to ask about autonomic symptoms such as orthostatic giddiness, changes in sweating, a blurred vision, dryness of the mouth, the eyes. So is it some sort of a more generalized autonomic dysfunction? Are there any other sort of neurological symptoms that may give away the underlying neurological diagnosis? But also discuss the lower urinary tract, the bowel, and the sexual functions, and ask those symptoms that are relevant to those. In addition to the standard uroneurology history take, we also need to ask about sensory symptoms from the pelvic floor and the organs. So from the lower urinary tract, ask about urethral sensations, whether the patient can feel that they're passing urine, whether the patient can feel that their bladder is getting full. Is it a graded sensation of fullness, or is it all or none? So nothing and then suddenly urgency. With regard to the bowel, likewise, with the anal sensations, when the patient defecates, can they feel the stool coming out? From the rectum, can they feel that the rectum is getting full? Do they get the sensations that the rectum is getting full? Can they make out between flatus and feces, which is a fine art, but patients who are neurologically intact would be able to make the discrimination between the two. From the genitalia, often a complaint is impaired numbness from the clitoris or from the vagina or from the penis, the scrotum. And then the question, the challenge to the neurologist is to make out whether when the patient says genital numbness, is it an impaired somatic sensations or impaired erogenous sensations? This distinction is quite subtle, but it's actually quite important because if it's an impaired somatic sensations, we're thinking in terms of a lesion of the S2-3 forwards or the pudendal nerve, whereas if it's an impairment of erogenous sensations, actually there isn't a neurological correlate to that. And of course, our assessments and our workup in the treatment of these patients would be different. If the patient is complaining of pelvic pain, which is a rather common entity in gynecological and urological practice, as a neurologist, we need to think about, could this be referred pain? So if we think of referred pain in an arm and leg, we know the direction of the pain, but if it's a lesion of the conus of the cauda, the pain will be referred to the pelvic floor or to the pelvic organs. So could it be a referred pain from a quadraconal lesion? Does the pain have characteristics of a pudendal neuralgia? Does the pain have characteristics of a cluneal neuropathy? So when we ask a few more history about the distribution of the pain, what triggers the pain, a history of, for example, cycling, for example, that then gives us a bit more insight into the sensory symptoms. Now, motor symptoms is not a lot that we can ask. A deterioration of pelvic floor squeeze, I think amongst men is very difficult to actually elicit because men are generally not aware of their pelvic floor muscles, whereas women, particularly women who've had children, know their pelvic floor muscles well, and they can actually often volunteer a history that their pelvic floor muscle squeeze has deteriorated over time. Some patients I see in clinic report pelvic floor spasms, and in inspection you'll find sort of quasi-purposive movements, and the EMG reveals sort of particular patterns of EMG activity. So this is a symptom that sometimes patients might volunteer. Part of the history taking is about medications, and there are two I would like to highlight this evening. One is on opiates, which most of you are aware of, have quite detrimental impact on urinary, bowel, and sexual complaints. So on the patient who complains of these symptoms, and if you find that there is a prescription for something like tramadol or morphine, then you need to think about, can the medication be responsible for their pelvic organ complaints? The other group I'd like to highlight are the antidepressants, particularly SSRIs, which are almost ubiquitous in any neurological prescription. And these can cause problems with sexual functions. In that group, I'd like to add 5-alpha reductase inhibitors, which in young people is used for treating baldness, for hair growth, and also isotretinoin, which is used for acne. And these are three groups of medications that are particularly known to have a detrimental impact on sexual functions. And for all these three groups, the patients usually describe a numb penis, genital sensations are impaired. It's a problem of erogenous sensations and not somatic sensations. These patients, when they're investigated, we find that their pudendal sensory root potentials are all normal. And classically, they have problems with ejaculation. That is actually more of a prominent problem than erectile dysfunction. The converse is what you expect in a patient with a structural neurological disease, like transverse myelitis. So if you see this pattern of ejaculatory problems more than erectile dysfunction, it should raise your suspicion that it could be some sort of medication that's resulting in this, and also poor orgasms. And between the SSRIs, as you can see, there are differences in the incidence of sexual dysfunction amongst these, but it's something to highlight, to be asked about in the history. Move on to the neurological examination. And unfortunately, the neurological examination is rather limited, but we do start with inspection. So this is a young gentleman who came to clinic with a history of urinary retention. When he was examined, you can make out clear atrophy in the interossei here in the right foot, the thinning of the calf muscle on the right compared to the left. You see this, this sort of a prominence here, which is actually a lipoma. So this patient actually had a spinal dysraphism with a lipoma. And his only presentation for the very first time in the 20s was avoiding dysfunction and retention, and had not reported any other sort of complaints. So he went through life till then with 2 different shoe sizes. And didn't think that it was anything significant. But it's only when he had his bladder problems did he come to medical attention. The sensory examination is also particularly important, and it's useful to keep a map like this in the clinic, because it is actually quite a complex innervation, because you can see the sacrodermatomes on the left, the lumbosacral dermatomes, and on the right you can see the individual nerves that innervate. And by mapping out the sensory impairment, if there is, sometimes we're able to come to a clinical diagnosis. If there's an injury to the cluneal nerve or an injury to the pudendal nerve, it sometimes becomes evident with an examination. But I would strongly recommend venturing out on this using a map in front of you, because then it becomes easier to actually come to pick up the abnormalities and see if it is indeed a neurological sensory loss or not. The motor examination is rather limited. I don't perform internal examinations in women, but I do perform rectal examinations. And as you can see, there are different layers of pelvic floor muscles, which I won't be going to in depth this evening. But essentially, it's not possible to study each of these muscles, but we can look at the different components, the anal sphincter and the levator muscles, in terms of their muscle tone, the muscle strength, exhaustion, pain. Very subjective examination, I must say. And then, of course, you have your reflexes. And as neurologists, you would be aware about the reflexes that are mediated through the sacral cord. So your anchor reflexes, S1, S2. Your S2, 3, 4 reflexes, the bulbar cavernous reflexes through S2, 3, 4 segments. And undoubtedly, you are familiar with how to elicit the bulbar cavernous reflex. And the anal reflex is sort of S2 to S5. And really, that's about it, examination-wise. I must say that it's often unrevealing, and that's really amongst them. I think the sensory examination is the one that's usually more informative. However, even then, it's sometimes quite a challenge to map out a sensory loss. Reflexes are sometimes useful, particularly the bulbocavernosus reflex. The anal reflex is sometimes difficult to elicit, especially in an obese individual. And so this is why we need to rely very much on investigations. So, of course, all of you would start with an MRI without doubt. What I would just like to remind everyone is that when we ask the radiologist to perform an MRI, is to make sure that, that they have taken axial sections, because sometimes when we ask for a lower spine, they might just take sagittal sections of the entire lower spine, and axial sections maybe through the upper lumbar, and then restricted to the upper sacral spine, but then don't go down to the lower, to the end of the sacrum. And so it's quite important to check that the entire sacrum has been imaged and you have axial sections. Also, it is useful to image the lumbosacral plexus, to image the sacral plexus and the pelvis. Now, this is a sequence that our neuroradiologists at Queen's Square have actually developed. It's a neurography sequence of the pudendal nerve. Now, you can't really see the pudendal nerve well. You see the pudendal neurovascular bundle, and this is the T1 weighted image. This is the STIR sequence. So in a healthy neurovascular bundle, it's not possible to make up between the vein and the nerve or the artery. However, if you start seeing, for example, engorged veins, then the radiologist is able to recognize that there is that there's a venous component of the bundle, and if there is any compressive effect on the pudendal nerve, then it becomes evident. But these are very clear images through the Alcock's canal that image the pudendal neurovascular bundle. This is showing the ischial-rectal branch, or the inferior rectal branch that's crossing through the ischial-rectal fossa on its way to the anal sphincter, which is here. And so, it's an immensely useful sequence in imaging the area. The yield, of course, depends upon your clinical findings. But sometimes we do reveal abnormalities which otherwise would be missed. The sequence that's used also images the sacral plexus, and so it gives us an idea about the sacral roots, the plexus, and the branches, plus the extent up to the pudendal nerve and the Alcock's canal. Now, we go back to the dichotomy of, as neurologists, we want to study the innervation directly, and we need to come back to the dichotomy of the innervation of the pelvic cavity. Remember, when it comes to the splanchnic innervation, as it is for any other, for the autonomic system, there is no way to directly evaluate your parasympathetic or sympathetic innervation to the lower urinary tract, the bowel, or the sexual organs. Now, what you can do, however, is get indirect information about the functioning of these organs. So a urodynamics, for example, will tell you the functions of the detrusor, activity at the level of the sphincter, for example. And so this gives us an indirect assessment. In centers where there is a dedicated functional gastroenterology team, anal rectal manometry will give you a wealth of information about rectal and anal sensations, plus about contractility at the level of the anal sphincter. So you get a wealth of information from these indirect assessments. And I think as neurologists who are interested in uro-neurology, I think it would be useful to learn how to interpret urodynamics, because your question that the answer to which you're looking for will be different from the question that a urologist asks. And so therefore it's useful to interpret and also sit with the urologist to share your questions, so that what you're looking for is something that they can then be focused upon. We talk about the somatic innervation, and there are direct assessments, and that's sort of the pelvic neurophysiology tests that are available. So you can assess the sensory pathways. So this is by the pudendal sensory evoked potentials. So it assesses the peripheral somatic afferent pathway plus the dorsal column. You have the peripheral motor innervation, which can be studied either by a pudendal motor terminal latency measurement or by pelvic floor EMG. And if you want to study the peripheral afferent and efferent limb of the sacral reflex arc, somatic reflex arc, you can record the bulbocavernosus reflex. And there is one evaluation of the sympathetic, cutaneous sympathetic innervation in the perineum, and that's by recording the perineal sympathetic skin response. So I'll briefly go through all of these, and I would like to quickly move on to some examples where the pelvic neurological examination is definitely helpful. So some of you are familiar with EMG, the pelvic floor. The key bit is that a sphincter EMG will never give you a period of electrical silence. And hence, if you're looking for spontaneous activity, you must do an EMG, the bulbospongiosus muscle. The anal sphincter EMG in particular is helpful to evaluate the nerve root injury, so pudendal nerve, or root injury, such as the sacral nerve roots, or any injury to the conus medullaris where the ONIF nucleus is damaged. And what we look for would be evidence of re-innervation. So you look at the length of the duration of the motor unit potentials and the amplitude. From the urethral sphincter EMG, one could do the exact same. However, we don't have standard values of duration or amplitudes, and hence we prefer the anal sphincter over the urethral sphincter for that reason. However, in some young women in retention, there are abnormal EMG findings that I'll come to. Now, those of you who are familiar with EMG, when you see these normal amplitudes, you find they're much, much smaller, and that's because essentially the motor units are much smaller for the sphincter muscles compared to your other striated muscles, but these are sort of the amplitudes that we usually get, and these are the durations. And conveniently, we plot the amplitude against the duration, and anything within this red box tends to be normal. Moving on to sensory evoked potential. So many of you are familiar with tibial sensory evoked potential. So you electrically stimulate the tibial nerve behind the medial malleolus, and you record from the from CZ dash. And you could do that. It's the same principle. You can stimulate the dorsal clitoral nerve or the dorsal penile nerve transcutaneously. The scalp electrodes are at the same position as one would record for the tibial SEPs. And like with tibial SEPs, we have to record a number of responses and have an average response just because they're small potentials. And those of you who are familiar with the actual trace of a tibial and sensory evoked potential, so this is a 186 centimeter high length of a person, and this is his tibial SEP recorded from the left side, following, this is the left tibial nerve stimulation, and you'll recognize the W-shaped sort of configuration, and the first downward deflection around 40 milliseconds, and that's particularly what we look at. This is the right tibial SEP. What you can find is when in this man, when the dorsal penile nerve is stimulated, so the pudendal SEP is a similar W waveform, and the downward deflection is at 40 milliseconds. We don't fully understand why the pudendal SEP is of a similar latency as the tibial SEP. The distance is shorter, so you'd expect it to be sooner than roughly 40 milliseconds, but this is what we find. Now, the challenge with pelvic neurophysiology is that there's very few nerves to study. There's only the pudendal nerve, and that's it. So unlike with the upper limb, you have the median, the ulnar, and the radial nerve. So here's particularly a case for developing what we call dermatomal sensory evoked potentials. So rather than stimulating a particular nerve trunk, you stimulate the dermatomes. So the largest dermatomes we stimulate are the S2 and the S3 dermatomes. I would like to do S4, however, it's rather inconsistent. So we can get a response like this. Once again, as you can make out the similar waveform and a similar latency as your pudendal SEP. This is following electrical stimulation of the S2 dermatome, and this is this trace. This figure is actually from the recorded from the cortex following stimulation of the S3 dermatome, and we adopt a similar operating procedure as we do for the pudendal sensory evoked potential recordings. Now, sometimes in a man with genital numbness, who complains of a numb penis, to evaluate the dorsal penile nerve functions, we perform nerve conduction studies, and we get a response like this. You can see it's a very short latency, and this is the sensory response that we receive. It's not possible to record in every patient, but it is something that we are developing. The bulbar cavernosus reflex, so this is something I think more neurologists would be familiar with, but essentially we assess both the afferent and the efferent sacral pathways. We stimulate the dorsal nerve of the penis, or the clitoris, depending on if it's a male or a female, and we record either from the bulbar cavernosus, which is what we prefer in our lab, or from the anal sphincter muscle using a concentric needle. And akin to sort of a blink reflex, we have a more reliable R1 component, which you can see here, which is roughly around sort of 33 to 38 milliseconds in latency. And then we have a less consistent R2 response. So using these different sort of neurophysiology tests that are in this column on the left, we are able to therefore evaluate the afferent, efferent component, and even the autonomic innervation to the pelvic floor. So I'll now go through some examples, and then please, if the chairpersons can tell me when time's up, I will stop. But scenario number 1 is a young woman in urinary retention, no urological cause is found. The patient's now referred to you for, is there a neurological cause for this woman's urinary retention? So we start thinking about, this is the history. So it's a young lady who had a laparoscopy for a fibroid and immediately post-operatively went into retention, partial improvement. She's no longer requiring a catheter. However, her post-void residues are persistently elevated. She has other bladder symptoms. Because her post-void residues are elevated, she's performing intermittent catheterization. No bowel complaints, no perineal sensory complaints. Your neurological examination is entirely normal. Of course, as a neurologist, if you think about a lesion of the conus, the cardia, you want to ask about the type of anesthesia, whether it's a spinal tap, whether the cardia, whether the sacral roots have been injured or not. But all that is negative. And this is the patient's urodynamics. And so I'll focus just on the abnormality, but essentially what you're seeing in this lower trace is the flow. So it's a very, very poor flow, but you see the detrusor pressure is very high. So high pressure, low flow. This means that there's something wrong with the outflow tract. It can be either a mechanical obstruction, such as a stricture, or a functional obstruction. Now, a mechanical obstruction is rather unlikely because it's a rather acute onset. So you think about something functional. So you think about detrusor sphincter dyssynergia, which is unlikely in this woman because neurologically the patient's intact. The MRI doesn't show any lesion to suggest detrusor sphincter dyssynergia. So we think about something at the outlet, a problem with the urethral sphincter. This is the urodynamics, which shows the poorly opening urethra. Now, this patient undergoes a test which measures the pressure within the urethra, and this is called the urethral pressure profile. And as compared to an age expected value of 58, hers is more than double, so an extremely high pressure. So this is now telling you that yes, there is something problem at the urethral, at the outflow, that for some reason the pressure within the urethral tube is high. So a urethral sphincter EMG is then performed, and I will play 2 recordings. This is the first one. So those of you who do EMGs will recognize this complex repetitive discharges, which is not necessarily abnormal for the urethral sphincter, but this is something else. So that's so from the complex repetitive discharge, what you're hearing is a rapidly firing burst of a high frequency activity, which is increasing or decreasing its firing rate. So it's not typical myotonia because it's not just decreasing. And so this is sort of called a decelerating burst. So this lady in retention has come to you as a neurologist. You performed an EMG, which is abnormal. They also have a high urethral pressure tone. So this lady has a primary disorder of urethral sphincter relaxation, otherwise known as Fowler syndrome. And these patients actually respond well to botulinum toxin injections of the sphincter, which is something I perform, or also sacral nerve stimulation, which is something that my urology colleagues perform. Now, why this is important to neurologists is that Fowler's keeps bad company. So women with Fowler's have a very high prevalence of other psychological comorbidities and functional neurological disorders. So we recently reviewed our cohort of women and found a high prevalence of chronic pain syndromes, of medically explained functional neurological symptoms, and also different mental health issues, which are greater than in other neurological populations. So for reasons we don't fully understand, there seems to be some sort of a relationship between this condition of primary disorder of urethral sphincter relaxation and FNDs. And other functional symptoms and psychological comorbidities. So this actually might throw you off because a patient might come to you with a weak limb or functional paraplegia, for example, with retention, and will be looking very, very hard for an organic cause because of the bladder involvement, when in fact they might be having a functional lower urinary tract dysfunction and a functional neurological disorder. And then the challenge is then how to link up the two and to evaluate both of them. We move on to scenario number 2. So a patient comes to you with a Parkinsonian syndrome, and the question that you have is, could it be a multiple system atrophy? So it's an elderly lady who presents with retention and severe incontinence, is telling you that there's some unsteadiness, some falls, and some poor dexterity. And we know that urogenital involvement often predates cardiovascular and other neurological problems in multiple system atrophy. We know that one of the reasons for this is that this is a neurodegenerative condition that particularly affects the spinal cord. So with degeneration of the bladder motor neurons, the patients develop incomplete bladder emptying and complete urinary retention. With involvement of the ONIF nucleus, there can be a degree of sphincter insufficiency, but the innervation of the sphincters are involved, and hence if you put a needle into the urethral or the anal sphincter, you get an abnormal sphincter EMG. So this is the EMG of a patient with multiple system atrophy. So remember the amplitudes and the durations from the earlier normal case I showed you. You can see these are much, much greater. Most of the dots are plotted outside the red line, and the mean duration of the motor unit potentials was 10.2 milliseconds, which is prolonged. What is actually quite particular is the very bizarre motor unit potentials that you get. So the normal motor unit duration is less than 10 milliseconds. This one is 38 milliseconds, and there are not many conditions that can result in such a prolonged motor unit potential. Those of you who perform EMG would probably have come across a case of MSA. Now, the key bit here is that the operator must measure the duration of the motor unit potentials themselves. They shouldn't leave it to the machine, because of what the machine does to this motor unit potential is it splits it up, and you get 1, 2, 3 different motor units that the machine records rather than the single one that's there. And so you don't get the 38 millisecond one, but you get multiple small ones if you leave it to an auto-MUP analysis. So it's quite important in MSA that if you suspected that you should have a manual MUP analysis. The sensitivity of anal sphincter EMG or bubble cavernosus reflex in differentiating between PD and MSA is low. However, the specificity is quite high. And so you will actually now find in the coming year or two a much more greater importance given to anal sphincter EMG in the diagnosis of its Parkinsonian plus conditions, just because it is the only test that'll tell you about degeneration occurring in the spinal cord, which none of the other tests that we do for Parkinsonian syndromes would tell you about. I move on to a third scenario. So this is a patient that some of you will come across, especially in the corporate sector, I think. A patient comes to you with penile numbness and sexual problems. And the question that the urologist or the andrologist is asking is there a neurological cause? So this is the clinical question here. So, and the key here is in your proper neurological examination, knowing the nerve territories of the different nerves of the penis to make out if there's a loss of tactile erogenous sensations. So you could use a cotton wool, you can use a neurotip. I have now moved on to using these Von Frey hairs because it provides a semi-objective assessment of tactile sensations, just because I get so many patients who come in with this complaint that it's often used to have some sort of quantification when performing the sensory examination. So this is a young man who came with problems of ejaculation and penile numbness. So in fact, his erectile functions were relatively preserved. And you can see the left tibio SCP, right tibio SCP are well formed, latencies are normal. there's no pudendal SCP, so it's absent. Now, this is an MRI scan, the MRI scan actually showed multiple neurofibromas affecting in the pelvic cavity, which is not only compressing the vas deferens and hence the cause for anejaculation, but also involving the sacral plexus and the pudendal nerves, and hence the sensory impairment and the absent pudendal SCP. So the neurologist, you're able to go back and say that it's not just a mechanical problem, but there is a neurological component that's contributing to this patient's sexual dysfunction. And lastly, this is a common scenario, is that a patient's reported an unexplained bladder, bowel, sexual dysfunction. Your clever urologist has ordered an MRI scan, thinking that he doesn't want to bother the neurologist. But then unfortunately, the MRI shows a spinal lesion, but it's really of a questionable relevance. So could it be like a disc that's maybe touching a nerve root rather than compressing? So in this situation, how would you approach the patient? So I give an example of a 49-year-old lady who presents with back pain of 8 months duration, bladder symptoms of 8 months, poor sensations of bladder fullness, hesitancy, double voiding, nocturia into 1, recurrent urinary infections, constipation, and tells about poor sensations when she's peeing, impaired anal rectal sensations, impaired vaginal sensations, discomfort during penetrative intercourse, and spontaneously occurring shooting pains in the vagina for 9 months. There's clearly a neurological flavor for this, I think, just from the poor sensations, the fact that there's also multi-pelvic organ involvement, so it's not just bladder, but bowel as well, but also there's sensory loss that the patient is describing her somatically as well. And lastly, you have these sort of spontaneously occurring shooting pains. So you think of some sort of a referred pain to the vagina. This is the MRI scan that was done. You can see the cystic lesion in the lower spinal canal. You can see these lesions of T1 and the hypointensive T1, hyperintensive T2. These are actually perineural cysts, which are called Tolov cysts. Now, Tolov cysts are quite common in the sacral canal. We don't know why, and hence many radiologists actually disregard the Tolov cysts, and in fact, many radiology centers, they don't even report them. But if a patient comes to you with pelvic organ complaints and the question is neurological, then of course these are quite relevant. So this is her flow test. So you might remember the bell-shaped curve that I showed last week. Here you find instead is an intermittent flow, and the patient has retained 200 ml. That's after the bladder was scanned. The urodynamic study showed a large capacity bladder with poor sensations, and there was a poor detrusor contraction. Now, the neurological examination revealed 70% impaired sensations over the S3 to S5 dermatomes bilaterally. So you can imagine from that map I showed earlier where the sensations are lost, and this is occurring bilaterally. The motor examination didn't reveal much, and in fact, in this lady, the anal reflex is actually present. So this is her neurophysiology. This is the anal sphincter EMG, the MUP, so you can see the individual motor unit potentials. And this is them plotted. You can see that there are several that are more than 10, several motor unit potentials that are more than 10 milliseconds in duration. Not many that have a high amplitude. Some of them have a long duration, of course. This is the tibiosensory evoked potential, not the best one to demonstrate in a session like this, but you can make out the waveform. This is the pudendal SCP, the same waveform. You can see there's clearly a P40 that can be marked here. Now, the S2 dermatoma sensory potential was not recordable. Neither was the S3 dermatoma SCP. So this patient, so she presents with sort of neurological symptoms in the perineum, incomplete bladder emptying with urinary retention. There's some abnormalities in neurophysiology, which would suggest that the sacral motor and so the sacral motor and sensory pathways at least in the somatic system, are involved. So one could therefore conclude that the Tolov cysts are indeed causing damage to the sacral innervation. Of course, remember that pelvic neurophysiology tells you only about the somatic innervation and not the splanchnic innervation. So we can't really definitely conclude that the bladder symptoms are because of the Tolov cysts. However, now that we know the somatic roots are involved, it's likely that the splanchnic innervation is involved as well. And so we then therefore deduce that this is all related to the Tolov cyst. So in conclusion, In patients with unexplained urogenital complaints, where you suspect a neurological cause, in conditions when there's multi-pelvic involvement, so it's not just one organ involved, but urinary, sexual, bowel, and different combinations of those. If they report perineal sensory complaints, if there's in particular urinary retention, and of course, if there's a presence of other neurological symptoms, then think about a neurological cause for those unexplained urogenital complaints. I've shared with you a structured approach to examine the patient and to evaluate the patient using radiology and neurophysiology. And in these particular situations, I think the pelvic neurological assessment is helpful to find a neurological cause for unexplained perineal sensory complaints.
Thank you very much, Jalesh. It was a wonderful lecture.
Thank you.
These are tests which we really never do in the routine examination, although they are useful. There are a few questions which I would like you to answer. One is, what is the current status of Fowler syndrome? Has it been discarded? He has not mentioned his name who has asked it.
So I think it's an important question to ask, because there is this entity of young women going into urinary retention, and there's been quite a bit of hype about the EMG changes. Now, it is known that in some women without bladder problems, that sometimes the EMG can show abnormal signals, particularly complex repetitive discharges. And so one has to be careful with making a diagnosis of Fowler syndrome. However, and it's the clinical context that's important. So a young woman who comes with voiding dysfunction, where you find a high urethral pressure tone, an abnormal EMG, there clearly is a group that's there. And it's important to recognize, because 70% of these women actually respond well to treatment with sacral neuromodulation, and a sizable percentage respond to botulinum toxin. So you're dealing with a potentially treatable condition, and that's why it's important to recognize. And the second reason, of course, is that they might come to you with maybe like a functional neurological disorder. And it's important to recognize that these women may also be in urinary retention, which might go unrecognized, so that can be managed along with their FNDs.
The next question is, actually, it's not very related. How commonly beta blockers are responsible for sexual dysfunction? Abhijit KK has asked this.
I think it's an extremely important cause. And if you find a man who comes to you with sexual dysfunction, and once again, the neurological causes being inquired about, if you find a beta blocker, then yes, you should certainly point that out, because it's something that I think we assume might not, but in fact, in practice, it is an important cause for erectile dysfunction.
The next question is, how to perform urethral and bulbocavernous EMG? Well, this is in the Indian context. There are very few people. I doubt if anybody is really doing these EMGs in India. Very few centers who are dedicated to doing EMG. I don't think they are doing much. Anyway, please.
Well, I mean, I must say it's a rather straightforward assessment. Because I think if we focus on if we start with the urethral sphincter EMG, any lab that does EMGs, it's the same equipment that's used. I think prepping the patient is a bit more important. So you spend time with the patient, explain what's going to happen. We give them local anesthetic as a cream that we apply, and also we give a local anesthetic injection. There will be a nurse or someone who will accompany me, so I'm chaperone, but they play an important role in actually chatting with the patient during the test. I would say that in most situations, actually, women are comfortable with the test. If it had been a terrible test, I would have stopped the test. And so even in women who are quite sensitive in that region, I think just speaking to the patient, chatting them up, having a nurse who chats them up, at the end, we find that it's actually not that bad of a test. The bulbospongiosus EMG, I don't perform in women yet, but we're developing that. But in men, it's you find the midline raphe, and just to the right or left of that in the perineum, you introduce a needle. So it's a situation where you're looking for spontaneous activity from one of the sacral or pudendal innervated muscles that you would choose. A lot of it is a mindset to the person who's performing the test. And I think if we are convinced that it's a useful test, you'll find that we're able to actually share that optimism and confidence with the patient. And I think they are tests that are not difficult to perform.
Rahil Ansari has asked, what amount of botulinum toxin is required to treat Fowler syndrome?
So a lot of it is a technique rather than the quantity, because it is usually EMG guided, and it's periurethally introduced. But essentially, what we published was it was onabotulinum toxin. That's Botox. So if you use onabotulinum toxin, it's what we found was 100 units was the amount that we found to be effective. If you give too much, what happens is that the sphincter muscle becomes weakened and the women can develop stress incontinence. And if you give too little, of course, it's not. Remember, this is a case of a high tone sphincter. The urethral pressure is high. The EMG is having a very strong, fast firing activity. So you need more than a small amount of botulinum toxin to relax the urethral sphincter. And so from our studies, we have found that 100 units of onabotulinum was the dosage, and that's what we use in our clinic.
Srinivas has asked, after toddler cyst removal, did the patient's symptoms resolve, the case that you had shown?
So I couldn't say specifically for this case, but in general, when the patients come back for us, it depends on which symptoms. So when you speak to the spinal surgeons, I think as you are aware, not many spinal surgeons do operate toddler cysts, but the ones who do, I think they're more focused on pain. And so the spinal surgeon I work with, he's quite optimistic that their pain improves. In fact, the patients who come back to us, they report that the pain improves. With regards to bladder and bowel complaints, I think it's early days because we're just now following up the patients. And I think it's sort of a mixed bag. You'll find some patients who are no longer catheterizing, who are doing quite well. And then you have other patients who are not doing so well. So it's difficult to say at this point. But what's clearly important is that these patients are suffering. They've got pain, they've got bladder bowel sexual complaints. It's something that we can't disregard. And if you have a procedure to potentially make them better, then it's important to monitor the patients. And this is where the neurologist's role is, because if you have the baseline assessments, after the surgery, the patients come back to you and you have something to compare, and you can then objectively follow up the patients.
Ashok Shirsat has asked, what is the therapy of idiopathic pudendal neuropathy? Why is the idiopathic pudendal neuropathy so difficult as compared to, say, idiopathic trigeminal neuralgia?
There's so many different theories that are proposed about pudendal neuralgia, and once a compressive etiology is excluded by some sort of imaging, the management is like trigeminal neuralgia. And I think we have a urogenital pain team, and they find that the pudendal nerve blocks to be particularly successful in this group. So I would agree that probably pharmacotherapy has a limited role for this group of patients. But I think under the care of anesthetists who have an interest in pain, I think you will find that these sort of different CT-guided nerve blocks are particularly effective in managing these symptoms.
Is there any role for carbamazepine or oxcarbamazepine in these patients? Do they respond to that?
I think you can try, because I think that the hypothesis, how we speculate, is it's similar. There's the increased expression of sodium channels, and they depolarize. But I think clinical practice, they're not that effective, and certainly those medications or gabapentin, pregabalin, they're not as effective, and that's why these sort of patients, I just refer them straight to an anesthetic team who can do a nerve block, because that's really the treatment I feel that these patients would benefit from.
Another anonymous attendee has asked, is the EMG needle used for routine EMG and sphincter EMG the same?
It is. It's the exact same needle. We tend to use a thinner gauge, like a 28 gauge needle, on some occasions. But it's a standard EMG needle that you would use. You can adapt the size if but the thinner the needle, the problem is it's more likely to bend when it's inside, especially when you're trying to find the urethral sphincter. So at the end of the day, I usually use a standard size EMG needle.
Right. I think we are at the end of the uh, questions. Ashok
Okay.
Shirsat has commented, Sunil, that this does not work, yaar. Anyway, thank you, Ashok, because I'm not very much into these kind of cases. Thank you, Jalesh. It was a pleasure to have you.
Thank you. Thank you very much.
Thank you, Jalesh. Thank you, and sorry for the delay. I think the technical part of it was a little delayed today, and so I.
No, that's fine. Thank you for having me.
Yeah,
Thank you
always
for all those lectures. And we'll have you again. We are going to have you again. Don't worry.
Yeah, we have tasted flesh. So Indian neurologists will be having you again and again.
Look forward to the bite.
Yeah.
Okay. Thank you. Bye.
Thank you. Good night. Good night.
Good night, Sunil. Sunil, good night.